So when we talk about ultra-high-risk myeloma, this term is of course slightly artificial. I think it emerged somewhat from that the traditional view of high-risk myeloma has an interaction with treatment. So the better the treatments get, inherently our view of high-risk myeloma somewhat changes. Some of the disease parts that we considered as having high risk actually do respond quite well to treatment improvements. For example, in our studies we have seen that patients with just an isolated ISS stage 3 without genetic high-risk markers are doing really better with the current treatments that we have available. So we felt, and others feel that as well, that ultra-high-risk is probably more fitting term for those patients that even with more modern triplet induction therapies, for example, still have adverse outcomes. And particularly these are patients who have a combination of risk markers. So I think it's probably clear that this is a complex disease. Myeloma is a complex disease. Thinking that we just would have one marker which would identify everything probably is a bit simplistic to start with. So it becomes really far more handleable and far more reliable as a predictive marker when we look at a range of markers and the co-occurrence of high-risk markers. So in terms of cytogenetics, we do know that there is a whole number of markers that are traditionally seen as high-risk markers: adverse translocations, T440 T1416, gain of 1q, deletion of 1p, deletion of 17p. But on their own, they are probably, with modern treatments, actually still having a better outcome. But when they co-occur, when we have two or more of these markers co-occurring, we call that in our trial, for example, double hit, then this is ultra-high risk in that a triplet therapy is still not overcoming it. And also standard one-agent maintenance therapy with lenalidomide does not really overcome it. We also found that a gene expression profile is adding a completely independent set of information to this. And I think personally this should really be considered more as part of a standard workup, although the access is still limited at the moment. It is a standard test that has diagnostic approval and can be run virtually in every diagnostic laboratory. So with these measures, of course, of identifying these patients, we do narrow in on patients that are now benefiting more, and we have had, fortunately, good results from the Optimum Mark9 trial with quintuplet induction and combination maintenance therapy. We think that's a pattern that we see here in other trials. For example, the top-line results of ISKIA also showing that those with co-occurring factors, so a double hit, seem to be really particularly benefiting from an intensified 4-drug regimen combination. So I think we're definitely making progress for these patients with ultra-high-risk disease, but it's an ongoing moving field, and I think it's a group that deserves our ongoing attention to improve their outcomes.